So idelalisib, would you give it as a single agent or with rituximab in follicular lymphoma? Yeah.
So the question is, idelalisib is approved as a single agent in patients with follicular lymphoma who have relapsed, who have failed at least 2 prior therapies. And then the question is, well, should we combine this with rituximab? And there is phase 2 data doing that. It's actually certainly also the regimen that led to the approval in relapsed chronic lymphocytic leukemia, CLL, is a combination of IDELA and rituximab. I don't know if it's required. I think it certainly provides an improvement in the response rate and certainly also provides a small incremental improvement in complete remission rate. But again, all these people will eventually relapse, and by the time you're thinking about using idelalisib in the first place, it's typically in people that have had so much rituximab that I'm not sure how much it would add for them. So I think in individual cases it's very reasonable, and in fact it's widely being done that way.
So if I remember correctly, in that study that led to the FDA approval of idelalisib, it was assumed that the patients had refractory disease to rituximab.
So that's right. You had to be refractory to rituximab, meaning that you had relapsed within 6 months of a prior rituximab-containing regimen. Of course, we know that many people who are in that setting will still respond to combinations of rituximab with other agents, despite the fact that they've seen a fair amount of it. So that's why it's commonly done. But it's really the patient population we were trying to target early on were those people who had really failed these kinds of agents and needed some different novel mechanism of action for cell killing. So adding rituximab, I think, is reasonable to do. I typically don't do it, and I don't think it's required or typically gives that kind of significant benefit for the reason that you mentioned.
Sure, thank you.
So a question for John. I have a patient I need your expertise in. A patient with follicular lymphoma that I had for 10 years, multiple therapies. Was almost had transformed into a larger B-cell lymphoma as well, but responded very well to idelalisib. And for a year, did well, but got admitted with pneumonitis, the one that you just mentioned, with very severe pneumonitis requiring high-flow oxygen. We stopped the drug, and basically she did not improve. Have you seen pneumonitis improve? We actually sent her home with high-flow oxygen and steroids, but that was after 2 weeks of keeping her in the hospital, and no change.
Yeah, this is an unfortunate situation that does happen with idelalisib. It can cause a very, very severe, long-lasting pneumonitis. I have had it happen in a fair number of patients, and I've had it reverse in the majority of them. They will recover and do fine with steroids. The key to it, of course, though, is being on, in my opinion, is being on top of it early. So again, it's when I mentioned in my talk, knowing about these side effects. So not just the pneumonitis, it's the diarrhea as well. Because if we can catch it early and get it treated with steroids, these people typically recover and do fine. Your patient may have a very long, prolonged course before really recovering significant pulmonary function, and maybe will never get back to baseline, unfortunately, and certainly not a patient you would re-challenge with the drug, as you obviously are already thinking.
So is there a time factor that you've seen, John? How long have you noticed it takes things to reverse?
Yeah,
you were starting worrying about lymphocytic relapse of lymphoma.
Yeah,
she
no.
was also transforming before a year ago.
Unfortunately, it can take many weeks. It can take, even a couple of months or even more with the pneumonitis. The diarrhea, it's not uncommon to take a handful of weeks. The pneumonitis, if it's severe, can take actually months, unfortunately.
Thanks.
Any other questions? Now, do you anticipate any of these targeted agents, idelalisib or ibrutinib, to be utilized as first-line agent in follicular lymphoma in near future?
Well, it's a controversial question, and I think it's like everything, right? These agents are very exciting. I think that they have a significant role for certain individual patients, but eventually, as we learn more, we will probably find some median ground where we'll figure out the right setting where to use it. Remember, we don't have really very long-term follow-up, major long-term follow-up data for years and years, actually, in patients who are on these drugs. And if we're asking a frontline patient to be taking one of these drugs indefinitely, perhaps for many, many years, that's a very unanswered question for many of these patients. If that's going to lead to relapses that will be different, much more aggressive perhaps, more areas of transformation perhaps, a lot of unanswered questions. Certainly ibrutinib is approved in the frontline setting for CLL, and in the right older patient in particular, in my practice, that's where I would see it. And I would see it eventually perhaps in indolent lymphomas in the same thing. It's a place where we don't really want to give chemoimmunotherapy to a patient. That's not a common patient, right? Most patients can handle reduced dose bendamustine and rituximab in the frontline setting, as an example. And then you also have other agents that most even older patients can tolerate. So until we get more long-term data, I think when we think about the fact of follicular lymphoma patients, we're not curing them with any of these new agents. A lot of people like to say, well, don't you want to get away from chemotherapy? I still personally believe that these are still chemotherapy agents. They're just not cytotoxic DNA damaging chemotherapy agents. They're still killing cancer cells. And so you could still think of them as chemotherapy agents, and they have side effects. Just because they're an oral agent doesn't mean they don't have side effects. We just heard from about Dr. Chaudhry's patient. So I would encourage patients not to be doing that in the frontline setting, for providers not to do that in the frontline setting for follicular lymphoma patients at this time.
Sure, thank you. Any other questions for Dr. Pagel? John, thank you.
Thank you for having me.
So now questions for Dr. Turtle and Dr. Venugopal.
Question for, can you hear me? Is on? Question for Dr. Venugopal. How do you determine who you do fish testing for MYC and BCL2 in your diffuse large B-cell lymphoma patients? Because in our lab, in our hospital, they seem very resistant to do fish testing. They do immunohistochemistry, and if there's expression there, they say to stop. Is there still a role to do fish testing those patients?
Good question. So the question is, which patients do you select and do fish testing for, say, MYC, for example? That's what you're doing. In our institution, we do immunohistochemistry for MYC in every patient with diffuse large B-cell lymphoma, and if it is positive, they automatically do fish for MYC as well as BCL2 and BCL6. Yeah. I mean, I think most laboratories where you send the specimen out, they do it too. I mean, the same way. I think most of the consults I receive from outside hospitals, the laboratory reports have much more molecular studies than what we do in our institution. We only do fish for patients who have IHC positivity. Do you have any?
Thank you.
Now, Dr. Venugopal, for gray zone lymphoma or mediastinal diffuse large B-cell lymphoma, the prognosis is not really very good. So do you think those patients should be offered preferably CAR T kind of treatment, or even the ABT 199 kind of therapy?
Okay, so primary mediastinal large cell lymphoma has many characteristics similar to Hodgkin's lymphoma, even at the gene profile, very close to Hodgkin's disease. So it's a curable disease if proper treatment is given. And the factors that affect curability are, of course, the size of the tumor first. I mean, if the size is bulky, many a time they will need consolidative radiation to get the cure rate. There is only one good phase 2 data. One phase 2 data from Wyndham Wilson showing that if you use dose-adjusted epoch with rituximab, you may be able to get away without radiation. Otherwise, typically, the bulky mass, these patients with bulky mass do get radiation. So I think if the patient relapses, then certainly other treatment options should be considered. I would say the standard second-line treatment if the patient relapses I would consider it a second-line chemotherapy followed by an autologous stem cell transplant, which still has a good cure rate. And I would consider CAR T in a patient who has relapse following a stem cell transplant.
What has your experience been with CAR T in gray zone and mediastinal diffuse large B-cell lymphoma?
I think it's been very similar to that of the other aggressive lymphomas, and that's with the caveat that we just haven't treated enough patients to really be able to say. You know, the slide that I showed of the patient who had the initial, what was thought to be a failure, that was a primary mediastinal or metastases from a primary mediastinal. It was actually very difficult histologically to distinguish between that and a grey zone. But we have seen patients who have done very well with those histologies. We've also seen patients who have just completely and utterly blown through and have had no effect whatsoever and failed dismally. So I think it's something that we still need to look into and treat more patients to see where we are.
Does age of the patient have any impact on the severity of toxicities that you encounter with CAR T?
Not so much on the severity of toxicity, but more on their ability to tolerate it. Obviously, the patients that, as I sort of mentioned during the talk, we've really seen the full spectrum of toxicity during dose escalation and when we've been working out various parameters, because none of these things were known about adjusting cell doses for tumour burden. So we certainly had patients who got very sick early on, and if you're on multiple presses with severe capillary leak and DIC, basically, the young people have a better chance of getting through that. Now we're really much better at dose adjusting and dealing with the toxicities as well. I didn't even talk about how we treat cytokine release syndrome, but we used to essentially, bad CRS, you want to try and shut down the T-cell activity, but early on in the study, we knew that these patients really had no other therapeutic options, so we would wait until the very sort of end of the rope before we would intervene. Now we're intervening a lot earlier in a much more refined way, just because we know more, and we're able to keep most patients out of ICU. So really there's not a huge difference as far as the toxicity goes with age. All that said and done, whenever we see, 84-year-old with lymphoma, what do you think?
Right.
It kind of goes to the bottom of the list, and I get very nervous about answering that email.
Sure.
The oldest patient we've treated is 74.
So with B-cell depletion that you see in CAR T therapy, does it have any long-term impact in terms of toxicities, like infections and other?
So you would think it should, but it really, we haven't seen it as a big problem so far, and we're not entirely sure why that is. We do give recommendations that are similar to the transplant recommendations if the IgG level is less than 400 to replace with monthly IVIG. And we haven't seen a huge problem with infections that's widespread across the population. We certainly have had some patients who've developed late infections, but it hasn't been nearly as big an issue as we thought it was going to be.
Sure. Any of this CAR T therapy in advanced stage of clinical trials, like phase 3?
So there are CAR T-cell therapies that are either, when we say advanced stage, that there are registration trials, not necessarily phase 3 trials, but registration trials going on from many of the different companies. So, I think probably the first approvals are likely to be in pediatric ALL and non-Hodgkin's lymphoma, with other approvals later on. I think a lot of the focus now is also looking into combination therapies. Combining checkpoint blockade, for example, with CAR T cells, looking at ibrutinib and CAR T cells, those sorts of things. The desire that often, or the question that often comes up is, are we going to move these earlier in the course of disease? I think that's a nice idea, but it's not ready to go that way yet. I think we still need to solve some of these issues of toxicity and the practicalities of actually, having patients travel to centres that can do it. So that's something that may be addressed in the future, but not at this stage.
Sure. Dr. Venugopal, for ABC subtype diffuse large B-cell lymphoma, the trial with R2-CHOP, which I presented at ASCO a couple of years ago, What are your thoughts about it? How often you use that treatment? Because based on the study, if I remember correctly, the patient did not have too many toxicities with
Right, I
R2-CHOP.
think it's a very, very good study. In fact, you saw the curves. Efficacy-wise, no question about that. And toxicity, most patients do tolerate it. I think the dose of lenalidomide is 25 milligram full dose, but day 1 to day 14 in a Q21 R-CHOP regimen. And a majority of patients tolerate it extremely well. So whether I would use it outside a clinical trial, I personally haven't. My colleagues in my hospital have used it and have been very impressed by the toxicity profile.
Sure. So it is something that can be utilized in ABC subtype, you suggest?
I think
Because-
so. I don't know if I can suggest it outside a clinical trial at this point because we don't have the approval.
The response rate was almost similar to the what we see in germinal center subtype.
Right. Basically, it mitigated the negative effect of the ABC subtype.
That's correct.
Yeah.